Hey everyone, home stretch. It's me again. My name is Reshma Ramachandran. I'm an assistant professor at Yale School of Medicine. In 4 minutes, I'll give you our theory of change regarding an area that folks have touched upon, which is the FDA, and I'll tie it to the affordability conversation and also one of the areas as a primary care physician where when I was in clinical practice, or I am in clinical practice, I find very frustrating in terms of not being able to control that area of cost in relation to my patients. I co-direct something called the Yale Collaboration for Regulatory Rigor, Integrity, and Transparency, or Yale CRIT. We are a group of clinicians, lawyers, public health experts, epidemiologists that work together to look at how drugs, devices, vaccines are regulated, approved, and covered towards improving patient outcomes. And the reason why we do this is because of our experience in seeing patients and seeing very clearly that they had questions that were oftentimes unanswered at the time of FDA approval. How does this medication interact with my other medications? Did they test this medication in clinical trials? Is it something that I need to take for my condition if there's no other options available? Has this been tested against non-pharmacological options that are available? And this is, as a primary care physician, I'm the person who oftentimes sees patients navigating specialty medications, specialty devices, and trying to help them understand what the value of these medications are and what the evidence is behind them. And oftentimes in reviewing the clinical trial evidence, finding that these answers are just not there. So the work that we do is a lot of research in the space and looking at clinical trial evidence and trying to voice that uncertainty for patients and clinicians around these novel technologies that oftentimes with FDA approval is kind of automatically assumed we should just have access to no matter what and no matter what the cost is, instead of interrogating, what are we providing access to and what does affordability mean in that context, and translating that research to different constituencies. So we publish a lot of research in this space in terms of the tools, regulation, the quality of clinical trial evidence. We actually directly engage with the public. So this comes in the form of op-eds that we write around specific product approvals, lab tests, medical devices, drugs that are approved, and trying to talk about the clinical consequences of just wholesale coverage or payment for these various products. We engage with patient advocacy organizations, with clinician organizations to talk about what does FDA approval mean and what is the level of uncertainty that we're sometimes accepting when there's flexibilities or kind of compromises made at that agency level in terms of access and affordability. Besides the public, we also engage directly with policymakers, and this is at different levels. So locally, health plans are trying to think about what should we actually include in our formulary, and is this actually beneficial for patients at the end of the day, and what does it mean for costs down the road in taking these products, right? Sometimes medications require a lot of services in terms of monitoring, right? More patient visits, more MRIs, more CAT scans over a period of time. Safety risks that come with that as well, that health plans have to take into consideration. So we try to inform them about that. We meet with folks within agencies, so both FDA, but also payers, so Medicare and Medicaid, that oftentimes have their hands tied in terms of what they have to cover that's FDA approved, and trying to walk through different tools for managing that as well. And also private payers too, who are balancing these sorts of risks. And then folks on Capitol Hill, including Congress, that are oftentimes lobbied by pharmaceutical companies and medical device companies to actually assume automatic coverage and payment, no matter what the cost is. In addition to those groups and policymakers, we also think about the courts. And I bring this up as a kind of a key point because the courts have actually changed pretty dramatically in recent years in terms of setting policy and not just statutory interpretation in many ways. So we oftentimes see companies engaging with the courts to shrink FDA's regulatory authority so that that sort of evidence around whether or not this therapy is actually beneficial, those questions remain unanswered, and also trying to hide evidence under the guise of commercial confidentiality or trade secrets. So we write amicus briefs. We sometimes even get involved in litigation to make data more available, just trying to think more holistically in terms of the different levers of power in terms of democratizing this sort of information, but also making sure that asymmetric information access that patients oftentimes experience is being diminished more and more. Then I'll just say finally, obviously we're at a big inflection point with what's happening at the FDA. The FDA is being actively dismantled. If folks haven't seen the news recently, we're seeing a lot of misinformation that's coming to patients, and I'm seeing this in my clinic. I have patients asking me questions about what they're seeing on television after press conferences or when the FDA commissioner goes in front of popular media around different products and misstating information. And this is choices that they're making with their hard-earned dollars about what they should access, either through prescriptions or sometimes through telehealth websites, right? Compounded medications as an example, peptides, GLP-1s, because the brand name option is not available. So in the midst of all that and having a regulator that is being actively dismantled, we are working on a Project 2029 for FDA that's engaging all constituencies, including patients, clinicians, public health officials, to really rethink and reimagine the role of a regulator in terms of ensuring affordability and access.
Hi, everyone. We are each sharing about 4 minutes about ourselves and then a reaction to the day. So I'll tell you about my work. I am an internal medicine physician and hospitalist. Started working in 2008 at Denver Health. Donalyn here is our CEO. And the patient population that inspired me to transition to research was the undocumented immigrant community with kidney failure. At the time, they could only receive dialysis once a week. And so as a hospital medicine physician, I took care of these patients every time they were hospitalized, so once a week. They were people that were stuck in the revolving door of the emergency department. So similar to the stories we talked about earlier today, where there is care that feels unjust and we are compelled to provide care that does not quite align with our ethics. And so in this situation, I became very close friends with a patient. Her name was Hilda. She was my age. She had 2 little boys. I had 2 little girls at the time. And I did everything I could to try to change this in the state. And after she died on Mother's Day in 2014, I was too distressed to continue to provide this kind of care to the rest of the undocumented immigrants with kidney failure, and started learning more about this issue. Are there other states that provide regular dialysis? And if they do, how did they do this? And realized very quickly that there was very little research. And so 6 years out, after being a full-time clinician, I completely transitioned and learned to do research and then started publishing on this like crazy. Meeting with community members and nonprofit community-based organizations. We formed a coalition and we changed access to care in Colorado in 2019 and have since changed this across the country. And now over half the country provides regular dialysis to undocumented immigrants. And that's something. And we've used this blueprint to continue to change access to care for other conditions, cancer, chronic conditions, and have continued to work with other states. And in fact, our whole team is out here hanging out with us, but we continue to do this across the country. And so thinking about my reflections and reactions to today, I think, I love what Miss Kate Walsh said, calling out the issues. And when we come across an injustice, for those of us that are clinicians, when we come across an injustice, do we come home and have a couple glasses of wine so that we can sleep and wake up and start another day? Or do we let it keep us up at night and decide to change it the next day? And if we decide to change it, do we persist? And do we engage others? Do we figure out the strategies to change this? And so I think my reflection from today, and I think someone earlier after the first panel had that question of, have we recorded this? Can we use AI to sort of distill some of the commonalities between the diverse opinions that were shared in healthcare policy? And how do we move forward, right? Because again, at the end of the day, we all have different political ideologies, but any one of us can get cancer and be stuck with a huge bill. And so my hope is that, that this day doesn't end today, that it continues on, and that those of you in this room that are inspired to persist, to leverage your professional resources, to leverage the LOWN Institute and other professional organizations that you represent, that we don't have a couple of glasses of wine tonight and forget about the conversation today, but that we instead take this to the next day.
Can we do both?
Yes.
Hi, everyone. My name is Chris Tsai. I am a general medicine fellow at Brigham, and my background, both my parents are Chinese immigrants, and growing up, I saw them navigate the healthcare system, and I saw them, when they were ill, they would rely on patchwork-free clinics, and that really made an impression on me. And I went to medical school at UCSF, and I decided to spend my time, my clinical rotations at San Francisco General, and then I went to Brigham and Women's, and I did my residency in internal medicine with a focus on primary care, and I trained at a federally qualified health center in Boston, Codman Square, and I've always been interested in working in the safety net. During medical school, I took some time off, and I worked in the House of Representatives, and I worked on the Medicare for All bill in the office of Representative Jayapal from Seattle. And I really liked that experience. I wanted to sort of combine an academic lens to a political debate, and so I really focused on the financing side, providing evidence to estimate the cost of legislation, what the bill would do for primary care, what it would do for safety net hospitals. And I'm completing my postdoc now with a focus on economic methods and prescription drug policy. And that's also at Brigham. And next year, I'll be joining the faculty at the University of Minnesota, where I'll be practicing at FQHC primary care, and also spending most of my time doing research. And I have to say, it was super humbling today. I learned from people I greatly admire, and I felt inspired, bewildered, overwhelmed, and it's hard to sort of think of what someone like me, who is very early in his career and who I feel has much to learn from many of the people in this room, could possibly say about the state of our healthcare system moving forward. And I was thinking, before I started medical training, I studied anthropology, and I remember reading the work of Paul Starr, and he described the state of the healthcare system in the 1900s, and he described U.S. policy reform as remedy and reaction, and how we come up with an idea that seems really great, employer-sponsored insurance, and then there's a reaction, and we see the downstream consequences of that. And he described the current state of the U.S. healthcare system as a policy trap, where no individual actor is happy completely with the state of the healthcare system. And it's an irrational system. It's an accident of history. It's not, no one picked this system, but it works just well enough for the right actors that it persists. And each additional reform is great. It helps. It's worthwhile, but it does entrench the policy trap, and it makes transformational reform more difficult. And that has always stuck with me, and it has made me, wonder what possibly you could do to sort of, what do societies do to get out of that trap? And I don't really know what the answer is, but what I have found sort of as I've learned more and more and spoken to people who have thought more thoughtfully about this is that the experience of patients, I think, has been the most satisfying and informative. I have worked in research and politics, but I think the most transformational and guiding experiences I've had have been in the clinic, taking care of my first day of residency, a 70-year-old woman from Haiti, refugee, never seen a physician before, coming in with dizziness, weight loss, hemoptysis, and as an intern, and that should not happen, but that was my experience, and using that to inform your broader work. So I still think about those words, the policy trap we're in, and I try to kind of think about what can you possibly do to try to, that is not really self-actualizing, but really actually tries to get at that as an individual. And does that mean talking to others who you don't normally talk to, being thoughtful, forming coalitions, taking advantage of crises? But that was sort of my reflection after hearing from some of the really informative talks we had today.
My name is Lana Gary. I am a breast cancer surgeon at Boston Medical Center. We've heard a lot about BMC today. So I think all of you will appreciate when I say that means in my day job, I take care of patients with breast cancer who cannot get care. elsewhere in the city, the state, and other parts of New England because of their insurance coverage. And so when Kate Walsh spoke about the medicalization of poverty, when I see people women with advanced disease who are presenting me beyond the scope of how I can treat them, it is surely because of their health-related social needs and outside of the scope of medicine as we think of it. My other hat is the Senior Physician Executive Fellow for Health Equity at the institution. And in that role, I think a lot about cancer care access for screen-detected cancer, so breast, lung, colon, cervical cancer. And my day job is essentially breaking down some of the silos that we have talked about to understand how patients move along the care continuum from department to department and what are the dollars associated with that, both revenue and cost, in order to either expand or support programs at our institution in a way to increase patient access and patient retention, as well as balance the hospital budget. And I think the word I kept hearing today was sort of accountability, and that someone needs to take accountability. I would argue that the someone is us in this room today need to take accountability for healthcare affordability. And we need to do that through narrative, through strategy, through transparency. The solution is going to be different for every individual, every institution, every state, whatever level you want to take it to. And we may disagree on how to get there, but we've also heard a lot today about all of the things that we do agree on. And so my takeaway is sort of how can I think about breaking down silos outside of my institution, outside of sort of my purview within my day job in order to have these conversations so that we can move forward for the common good.
Hi, everyone. My name is Apurva Ram. I wanted to start just by saying how grateful I am to be here with all of these other amazing people and everyone in the room, and also to have listened to so many experts throughout the day talk about potential policy solutions to our non-system that we have here in America. A little bit about myself. My journey into this world of policy and advocacy began as a resident when I first sort of had my eyes opened in infinite detail to sort of the non-system and the way that that fails the patients that I took care of. I've now seen that echoed kind of throughout all of the learners that I work with as well. And advocacy for me was a way to kind of counter some of that burnout and some of that distress and moral injury that you feel in the system as you're going through it and learning from it that you can't make any change. That's what I was told, right? Now, flash forward to my job in today's world, and I'm half the time a primary care doctor internist, seeing the impact of the system on my colleagues and on my patients. The other half of the time, I'm teaching residents, medical students, and conducting advocacy work. And a lot of my main focus when it comes to education is actually how do we bridge that gap between there are problems in our system and you can do something about that. I think it's actually funny. I also studied anthropology before I became a doctor, so maybe that's a common thread, and we should be getting more people into anthropology. But, how do we change the culture? And I think a lot of that starts with our basic education. I hear over and over again from residents and student doctors, and I'm sure in other health professionals that I don't have access to, we know what's wrong with the system. And while that may or may not be true, the follow-up is always, why can't you ever tell me what I can do about it? And so I think my big takeaway from today is we may not have the actual specific solution. Like I can't go and I can't tell them with 100% certainty, this is how we fix the healthcare system. I might think I know that answer. I don't. I definitely don't think I know that answer, but I might. But I think the question is, how can we incorporate this talk of solutions and talk of agency into our basic education in healthcare workers? And I'm focusing very much on healthcare workers because I think that healthcare workers are a perfect bridge between patients who are often not empowered to make change as much as I wish that they were, and the larger, more powerful people. And so as healthcare workers, I think we have that ability more than probably anyone else in the system. And we all went into this field to help other people. And this is just another part of that job. So my big reflection, my big takeaway is all of these solutions that I'm hearing, I want to start incorporating that into education as early as possible. And I want to start implementing that not just in separate little lectures on advocacy and policy, right? But you have a lecture on hypertension and you talk about social and structural disparities, but you also talk about solutions and policy solutions to fixing those disparities. And that's my hope, is that if we incorporate this kind of across the education side of the spectrum, we can build more physician advocates, we can change the culture in medicine, and hopefully push that forward into larger policy change. Thanks.
So thanks to everybody. Obviously, some common threads that were reflective earlier of the day, especially around how individual patient stories have led to thinking about solutions more systemically, thinking about working in coalitions, oftentimes with unlikely bedfellows to encourage larger solutions, systems thinking change, and also thinking about empowerment of various constituencies towards that goal. We're going to this is the time and hopefully the opportunity to get interactive. We're wanting to make sure that the lessons from today, don't go, in one year and out the other and get forgotten. So for the next 30 minutes, we're going to break out into tabletop discussions, and we encourage folks, especially at these tables, to fill up your tables as much as possible so that we can have a varied group of folks discussing the various issues that are coming that you'll be asked to answer about. If you're sitting at the table, that's your group. And for those who are in the theater seating, come fill this up before moving into the other room as well. There's an adjacent room where there's going to be tables there for of groups of 7 to 8. They'll be there. And Lily will now give some instructions more specifically around the questions you'll be answering at your table.
All right, you'll see a worksheet with 2 questions at your table. It's your individual table worksheet. We want you to take time to think, reflect, and discuss those questions with the people at your table. And you'll also see a yellow worksheet at the table that should be filled out by your note taker, ideally the youngest person at your table. And then we'll be checking with all of you. You have about 15 minutes per question, and we're going to come back at 4:50 and do report out. Is it 4:50?
Right, 4:30.
4:30.
Everybody, we're going to get back to reporting out from all of the groups. I know there was a ton of really interesting conversations. I think we have the difficult task of trying to summarize it quickly. I'm going to start with what I heard about the 2040 question. So it's 2040. We magically fixed everything. What did we do when we waved our magic wand? Across the board, a couple of things that I heard at 2 different tables was some sort of regulation of the corporatization and consolidation in healthcare. That ranged from sort of removing the profit motive completely to just increasing kind of regulations on the capitalism and capitalistic society. Another big component that seemed across the board, which I was very happy to hear as a primary care doctor, was increasing the proportion of primary care spend. That was across the board as well. And then universal coverage was kind of the other third big one that I heard. Another interesting kind of runner-up was this idea of rationing came up at a couple different groups. And so no one, I think, called it rationing, but that was the way I was thinking about it, which is, someone sort of has to lose, or certain things will have to be regulated, not just for costs, but also in terms of what kind of care we can provide with a set amount of money. And so I think that was also something that happened across the group. I don't think both my groups got all the way to the second question, but I'm going to say for the right now changes, I saw a lot about sort of cross institution discussions and working with people that you are perhaps not aligned with on first glance, and then really focusing on sort of community-driven changes. But I will hand it off to see what other groups said.
Yeah. So looking at my sheets to try to call out some different things for the 2040 question, one of my tables, a thing that really resonated with me was that we need a value shift in this country, and using social movements to get there. And so organizing sort of at the patient level, at the frontline provider level, at the people who experience sort of the consequences of this every day, and bringing together our power so that we can shift the narrative at higher levels where decisions are made. And I really like that. Also, leveraging technology to reduce low-value care and increase access to care, and again, sort of universal coverage. I think that there's no way out of this unless we cover everyone. And I'm going to tack on my 2 cents of coverage does not always equal access. So making sure that, like, in what we're really saying is people need universal access to care. And then at my tables, we did sort of something pretty similar of everybody sort of went around thinking about how they can leverage their current skill sets tomorrow to keep this conversation going. And again, we talked a lot about breaking down silos, networking together, continuing this conversation, even with people at first glance who we may not align on. How can we build a bigger tent?
Those are great, and I won't repeat things that have already been said. One kind of thread I liked was just general price reform, and for example, in the case of prescription drugs, tying medication pricing to the added clinical value as our peer countries do, rather than allowing prices to be set just sort of at what the market will bear. Similarly, like thinking about other financing reforms like global payments, and one thread was also that I brought up was the importance of voting reform, which has historically always accompanied major healthcare reforms dating back to Medicare, and many of these policies are very popular, but because of the state of our democracy, they're not likely to be implemented. So things like Citizens United and campaign finance reform might need to be the first domino to fall realistically. And then how to actually engage with these, writing and working with policymakers, and really organizing your local communities were some common threads that occurred.
Hi. So what 3 things did we do to get there? A lot of what we discussed has been mentioned, but at the end of the day, our table decided that reclaiming the narrative, collaboration, coordination, and creating transparency got us there. And then one thing you can do at your institution, so grants that specifically address this, physician education, and sharing knowledge on how states have addressed affordability across the country. So this means sharing strategies that have successfully changed this across the country.
All right. For the first question, both the tables I was at actually try to address this issue around politics and policy. We've talked about various different policies that might be viable, but just an acknowledgement that politics might be the barrier for enacting those policies. And so the tables actually went as far as saying like banning corporate lobbying altogether by 2040, so that healthcare stakeholders don't have privileged access necessarily for changing policy. The other sort of thread that came through both tables was the sort of acknowledgement that health doesn't exist in a vacuum. It's actually across different sectors, including thinking about planetary health, but also just income inequality, thinking about just social services just generally. And so the need for all of those sorts of issues to be addressed in order to improve health and health affordability as being necessary as well. I think for the next question in terms of what you can do now, a lot of the threads are actually related in terms of thinking about education across all sorts of constituencies, the general public, clinicians, folks within the healthcare stakeholder space just generally, one, to even the playing field across different parties for that. And then in order to enable that, ensuring transparency across the healthcare system so that people can be able to engage in health change. And then I think kind of similarly to what folks just said, just participating more locally to be able to enact change and also providing hopefully a proof of concept for more global change altogether so that these changes can actually be realized. So, I mean, I think kind of a lot of shared reflections, it seemed from all the tables. And hopefully, Vikas will let us know how we can actually enact some of these things in coalition with folks. Easy changes, no problem. But I just want to say thank you to all of you and all the speakers for assisting in the report back. We really appreciate actually this opportunity to think big and think small, especially after such a stellar day of so many reflections across different aspects of healthcare about the changes that we need to see in order to enable affordability for our patients, but also the healthcare system writ large. So please give a round of applause to you all for coming up with these changes, and also to our speakers here as well.